Yes, we're actually going to tag team the introductions today, and I have the pleasure of starting us off. As we've been doing, I'd like to start with a land acknowledgement of the land that we are on here. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. The university resides on Dakota land ceded in the treaties of 1837 and 1851. The Division of Epidemiology and Community Health acknowledges this land as a complex and layered history. This land acknowledgement is one of the ways in which we work to educate the campus and community about this land and our relationships with it and with each other. The division is committed to ongoing efforts to recognize, support, and advocate for American Indian nations and people. So welcome again. My name is Ruth Wood, if we haven't met. I want to just quickly announce that next week's seminar is actually what we call an in-service. So the purpose of the in-service is really to give us all more hands-on next steps for different topics that we face every day. And next week's in-service is going to be focused on this grand issue of diversity, equity, and inclusion. And the topic specifically will be about religious inclusivity. And so the title of next week's talk, that will be presented by Britt Newby, who is a chaplain, is Know Your Neighbor, Creating a Religiously Inclusive Campus. So we're excited about that as well. Like I said, we'll be tag teaming our introductions today, so I'm really excited to introduce our next introducer. And we're actually going to take a second and show you how spiritually close we are. Rachel Williams is not only my colleague and friend and neighbor and duet partner, but look at this. We actually matched today. We have no idea we're going to match. We're in the converse of each other. She's also so welcome. Thank you for doing that. Introduction.
Thank you for that lovely introduction. I promise I don't have too many more people to introduce. So I've been looking forward to this seminar for quite some time. There are two fantastic speakers here today. One is actually on Zoom because she's under the weather, unfortunately. I know that Elizabeth was really looking forward to being here in person and getting to talk to people in person, but she's at home protecting the herd. So first, I want to introduce Elizabeth Wrigley Field, who some of you, I'm sure, already know. She's an assistant professor here in our Department of Sociology, and she's a very involved faculty member in the Minnesota Population Center. She is a sociologist and a demographer, a demographic methodologist, and she specializes in racial inequality and mortality, and both in contemporary and historical infectious diseases. There's a couple things I want to highlight about Elizabeth, because it also highlights another one of our students here in this division who isn't up on the stage today. But something that's a little bit unique about Elizabeth as a sociologist, and I'm sorry, Elizabeth, that sounded weird for a sociologist, but she's not just involved in her sociological demographic stuff, but she's also very involved in community work around vaccine equity. And this work, which she's done in partnership with several community partners and is co-led by one of our students, Inari Mohammed, has recently been recognized in a lot of different ways. It's been featured in the Atlantic. Elizabeth was recognized at the Interdisciplinary Association for Population Health Policy, IAPHS annual meeting, where she got the Public Engagement Award for this work. And she and Inari were recently on NPR with Ed Young talking about this work. So that's not something that's going to be talked about today, but it's also something exciting that she's involved in. The second, I promise this isn't going to be all introduction. The second person I need to introduce, who I'm sure many of you already know, is our doctoral candidate, Katie Berry, who is right here in person. She's feeling well, thankfully. She is a fourth-year PhD student and also has been involved in the MPC's training program. She's currently an F31 predoctoral fellow funded by NICHD. And her dissertation research is going to examine how social policy and specifically policy that impacts people with criminal histories, affects their mental health and their families' mental health. So thank you very much, Katie and Elizabeth, and I will finally hand this over to both of you.
Thank you, Rachel. Thanks everyone for being here. I think Elizabeth is going to kick us off.
I will. Thank you, Rachel, for the introduction, and thank you everyone, Ruby, for inviting us. I am truly disappointed not to be there in person. I was trying to be responsible, but it is a disappointment because, you know, I'm here on the same campus working on health, and I haven't actually gotten to meet that many of you over in Epi in person, and I would really like to, but you know, if something in the talk catches your interest, feel very free to reach out. It would just be great to be more connected here at the U. But Katie and I are going to present some work. You can advance this slide, Katie. Some work that tackles two current narratives about COVID deaths. And we want to use some of our recent research to assess the extent to which these current narratives are true with respect to the lens of racial inequality in COVID deaths. And these two narratives are the idea that we now have a more equal pandemic, that racial disparities have shrunk, and that we're in a pandemic of the unvaccinated. And then finally, next slide. So I'm going to do the first one of those. Katie's going to do the second, and then we'll pop back to me to end with some research just briefly that really changed the way that I view pandemic mortality and what it has to tell us about racial inequality in the United States. So that's the overview, and we will just get into it. So first, is this now a more equal pandemic? Next slide. Katie is already regretting that my slide style is to have a lot of slides that advance quickly. Thank you for your service.
No problem.
So the idea that we're now in a more equal pandemic, this is the narrative that has been really prominently put forward, among others, by David Leonhardt, who writes the very influential column The Morning at the New York Times. So in this column titled A Public Health Success Story, he writes, "The racial gap in death rates has disappeared. That disappearance is arguably one of Biden's greatest accomplishments." And so the first chunk of research we're going to show is speaking to, is this actually true? Next slide. And the research that I'm going to show that bears on this is an article which is currently under review, so it's not yet peer-reviewed. And it looks at the first 2 years of pandemic mortality. The senior author of this large research team is Andrew Stokes. The first author is D.L. Lundberg, an outstanding researcher. They're both at Boston University, where most of this team is. So I'm going to show you just a smattering of results that collectively bear on this question of, has this become a more equal pandemic? Next slide. The setup here is we're looking at official COVID deaths. And what that means for us is COVID appears anywhere on the death certificate. We're not too concerned about where it appears. If it's there, it's a COVID death. If it's not, it's not. And we're looking at COVID deaths by time, race, ethnicity, and geography. All of our analysis is based on county level mortality for these specific groups, which we then aggregate in different ways. And so a huge amount of the work of this project, which I contributed absolutely nothing to, it was figuring out how to work with NCHS data suppression rules to get as much information as possible about what are sometimes small cells. So just doing a lot to kind of trade off different levels of aggregation to get as much information as we could. And the senior author on this paper, Andrew Stokes, is just an absolute master at this. So that's the behind the scenes work, or some of it, that went into these results. The time dimension is we're comparing the pandemic's first year of March 2020 to February 2021 deaths, meaning deaths that overwhelmingly stemmed from infections that occurred before vaccination was available. So deaths in February 2021, a small number of those vaccination would have been available before the person was infected, but not very many. And then the comparison is to deaths in March 2021 to February 2022. So most of those happened after vaccines were widely available in the US. We're looking at multiple racial and ethnic groups in 3 kinds of geographies, which are big metro areas, small metro areas, and rural areas. Okay, so enough setup. Here's some results. Next, so first of all, there is not a consistent change in mortality between the pandemic's first and second years. The change in mortality depends on who you are and where you are. Next slide. Across the board, geographically, mortality fell for Black, Hispanic, Asian, and Native people. In all kinds of geographies, the second year of the pandemic was safer for those groups. For the Native Hawaiian and Pacific Islander population, mortality increased quite a lot in relative terms. In non-metro areas, which include some of Hawaii's islands, it otherwise decreased. And next slide. White mortality increased everywhere except in major metro areas. And major metro areas here doesn't just mean like the inner core of cities. It also means like suburbs and exurbs of major cities. So those are really the exception, but everywhere else, smaller towns, smaller cities, rural areas, white mortality increased. So this is just a very different pattern for white people compared with people of color as a whole. That's the first result. Next, we look at how the geographic patterning of COVID deaths shifted over time and how that intersects with race. And what we find out is that COVID mortality shifted to rural areas mostly very early. So this is for age standardized COVID mortality. It becomes greater in rural areas than in large metros in the summer of 2022 for Black and white populations, although not until a year later for Hispanic populations, which is interesting thinking about how hard agricultural workers were hit by the pandemic. We actually see in relative terms their disadvantage begins well into the period of vaccine availability. Now, of course, rural areas on average are more white. So the shifting of deaths into areas where the white population is disproportionately living, that geographic shift is intensifying the fact that white mortality also got worse specifically in rural areas, even after vaccines were available. So there's this kind of geographic and racial interaction here that's leading the white population in rural areas to increasingly be where COVID deaths were concentrated. Next slide.
Elizabeth, it's hard to get slide. Could you just, it seems important, could you just orient us to the colors and what?
Oh yeah, I'm sorry about that. I was trying to get through this one a little quickly, but that is important. So the y-axis here is age standardized mortality. The x-axis is time. And the red dots are kind of breaking the red dashed lines are breaking time into different COVID waves. The initial wave in 2 parts, then alpha, then delta, then Omicron. The top is the total US population. And then the panels are white, Black, and Hispanic. And the lines are geographies. So the red lines are large metro, green are medium and small metro, and blue lines are non-metro. And so in terms of the narrative that I'm highlighting on this slide, the thing to look for is when do the blue lines overtake the other lines on each panel? And the key pattern is that basically with the exception of the Hispanic population, that's a little bit different. It happens super early on. It's like as early as the first, as the later parts of the initial COVID wave or the alpha wave. It's already rural mortality that's higher than metro mortality, which I'll just say is actually a lot earlier than I had understood before we looked at this. I thought that shift happened a lot later than the summer of 2020.
Thank you.
And thank you for reminding me not to skimp on explanation. Okay. So this result is statistically related to vaccination rates, and I will explain this slide a little bit better. But so remember that all of our measures here are at the county level. We can't see what happens to vaccinated or unvaccinated individuals. But this graph is showing at the county level, the county percent vaccination on the x-axis for all adults in the county, and the change in death rates from the pandemic's first year to its second year on the y-axis. Being above the 0 line, which is about a third of the way down the graph, means mortality increased. Below that, it decreased. And the panels are Hispanic, Black, and white from left to right. The colors are telling you the type of geography. So again, it's non-metro in blue, medium and small metro in green, and large metro in red. And so a couple of things that stand out here. First is right away, you can see that there's this real gradient where vaccination is high in big cities and their outlying areas, low in rural areas, and in between in small metro areas. And that's actually a quite consistent gradient. You can also see that mortality fell in counties that have high vaccination rates. It fell for everyone. And it also fell for Black and Hispanic people, regardless of the type of county or the level of vaccination. Although for Hispanic people, mortality did fall much more sharply in more vaccinated counties. That's not as true for Black people. But for white people, mortality fell in the highly vaccinated big metro areas. It stayed about the same in the medium metro areas and the large metro counties that were less vaccinated than the others. And it rose in the rural areas, which is also where vaccination was low. And because this geography vaccination gradient is so consistent, those two things are really confounded with one another. So even just descriptively, we can't really separate them and say, you know, the increase in mortality seems like it's really related to vaccination, or it's really related to other things about being a rural county. They're very tightly packaged together. So one last result from this paper. Next slide. So this is the same kind of graph as before, but we've switched racial groups with geographies. So again, here the x-axis is time and the y-axis is age standardized mortality. But now the panels are the whole country, large metro areas, medium, small metro areas, or non-metro. And the colors are now Hispanic is red, non-Hispanic Black is green, and non-Hispanic white is blue. And the key thing that I want you to take from this graph is that there's this pattern where every time there's a surge, Black and Hispanic mortality surge the most, and the racial disparities get large. But in between surges, mortality rates converge, Black and Hispanic mortality rates converge back down toward white levels. And so the surges are really what is driving the inequity, not only because that's when most deaths occur, but also because that's when the deaths are most unequal. By the way, you may have also seen a result like this in the Washington Post recently. Those reporters found it independently of us while our piece has been sitting under review, and they did a really good job of it. So I recommend that article very highly. One final thought on this surge results. This is not in this paper. It's the idea of maybe a next paper, which I've been kind of kicking around with a few people. So I'll just sort of throw it out. So I have the idea, and you all being epidemiologists who are more knowledgeable about this than me can actually tell me what's wrong with this. But I have this idea that at this stage of the pandemic, when mitigation is very limited and most people are living lives that might yield relatively similar levels of exposure, relative to whatever is the sort of background rate of COVID circulating in their area, that in that context, the demographic patterning of mortality between surges is a pretty decent proxy for the demographic patterning of infection fatality. That basically that's what mortality patterns are picking up. And right now, a lot of that infection fatality, though absolutely not all of it, but a lot of it is patterned by vaccination patterns. And so in between surges, is when we would see this kind of white mortality in these under-vaccinated areas really coming to the fore. But in surges, once people recognize there's a surge, people can adopt mitigations to the extent to which their lives afford them the ability to do that. And so you would see risk then correlating much more with advantage, and the demographic patterning of mortality would become much more about the patterning of exposure. And if that's right, then I think it means that if we want to think about how is risk going to be patterned in the medium-term future, we can kind of break that problem down into pieces, which are the infection mortality driving the mortality, the infection fatality driving the mortality during lull periods, which will have a lot to do with vaccination rates, but also how mortality evolves conditional on vaccination with new variants, with new vaccines, and with repeated infections. Second, with the exposure patterns during surges. And then finally, and I think unknowably, certainly to me, the number and intensity of future surges. And so maybe that's a helpful framework for thinking about like how our racial disparity is going to be evolving in the next couple of years. Okay, so that concludes the wild speculation portion of what I will say. Next slide. So putting all of this together, was this narrative about this is a more equal pandemic correct? Next slide. So the disparities today are smaller. They were smaller in the pandemic's second year. They're still smaller today in the third year than they were early on. This is partly, but not wholly, driven by a shift in mortality to more rural areas where more white people live. But it's also driven not just by declining mortality among populations of color, though that's true, but also by increasing mortality in many white populations. And so is that a public health success story, as this headline announces, or is it just an idiosyncrasy in the way that this particular public health failure has been a failure? And what will happen when we're no longer between surges, but once again in one? Will this still look like a more equal pandemic at all? So with that, I will turn this over to Katie for our second piece.
All right, thanks, Elizabeth. So is this now a pandemic of the unvaccinated? I'm sure everyone has heard this framing by now. Since last summer, the pandemic of the unvaccinated narrative has been used heavily by government officials. For example, in summer 2021, Rochelle Walensky, who's the CDC director, said there's a clear message that is coming through. This is becoming a pandemic of the unvaccinated. And President Biden quickly adopted this messaging as well and has continued to use it heavily. For example, in January of this year, Biden said, this continues to be a pandemic of the unvaccinated, so we got to make more progress. And this narrative has gotten a little bit of pushback for a couple of reasons. One, because it may stigmatize unvaccinated individuals and is unlikely to motivate this group to change their behavior and get vaccinated. And two, because it may no longer be quite as accurate of a portrayal of what's going on in the Delta and Omicron periods. And these are really important issues, but what we want to focus on today is whether the pandemic of the unvaccinated framing is consistent with how racial inequity in COVID has evolved over time. So it would be really helpful to understand exactly how vaccination patterns are contributing to changing racial disparities in COVID mortality. But one reason this is difficult to do is because there are very, very few sources of data that present vaccination rates by both race and age at the same time. And this is really important. This matters because like COVID mortality, COVID vaccination is hugely age dependent. And we know that the white population in the US is substantially older than other groups. So just looking at race or ethnicity specific vaccination rates doesn't tell us the whole story. So to better understand vaccination patterns at the end of 2021, our team looked at COVID vaccination rates for different racial or ethnic groups adjusted for age. And what we did was we started with data on race-specific vaccinations from each state, and we used indirect age standardization to reveal racial vaccination patterns net of the shared pattern that older people are more likely than younger people to be vaccinated. And this is what we found. These violin plots show the indirectly age standardized vaccination rates for states grouped by race and ethnicity. And when these standardized rates exceed 1, that means that the group in question is more vaccinated than we would predict based on their age distribution. And when the rates are less than 1, the group is less vaccinated than we would expect. So what we see here is that there are basically 2 under-vaccinated populations in the US relative to their age distributions. And those are the Black population and the white population. And so this analysis is informative, and it gives us insight into COVID vaccination patterns for different racial groups, but it doesn't really tell us anything about how this relates to mortality and how racial inequality in COVID mortality has evolved with changing vaccination patterns. So we then use data from Minnesota to look at how racial groups' vaccination rates relate to one another, specifically focusing on the midlife time age frame. And I'm going to walk you through these results in detail, which actually were just published in the American Journal of Preventive Medicine last week. So we're very, very excited about that. But before we get to the results, why study Minnesota specifically? We look at Minnesota because our state is very, very unusual in making vaccination data available by both race and age simultaneously. So Minnesota presents a unique opportunity to look at racial vaccination patterns within specific age groups. And why do we end up focusing on midlife specifically? As I mentioned, both COVID vaccinations and mortality are so sensitive to age that it really only makes sense to ask this question in an age-specific way. So we look at patterns, vaccination patterns and mortality patterns within 3 broad age categories: younger adults, middle-aged adults, and older adults. And then we zoom in and focus on midlife specifically for 2 big reasons. One reason is that midlife mortality is just very distinctive. Midlife mortality has always been higher in the US relative to our international peers, and racial inequality is a huge reason why. Midlife mortality is also a really key part of why COVID mortality in particular has been so much higher here than in many of our peer countries. And so the articles on this slide, which were not written by our team, but by some collaborators and academic friends, they show they're all extremely excellent investigations that draw out different pieces of this. But the big picture here is that we believe midlife mortality is central to the story of racial inequity in COVID. So there's clearly a substantive reason to focus on midlife, but there's also a practical one. Unfortunately, we can't accurately assess vaccination rates for elder. We have a question?
Yeah, just a quick clarification. Age range for midlife, please.
We are going to focus on ages 45 to 64.
Thank you.
Hopefully that doesn't offend anyone in the room, that classification. So as I was saying, we can't accurately assess vaccination rates for elderly ages with this Minnesota data. This is a screenshot of the state's data dashboard for vaccination rates. And the group up on the screen here is adults age 65 and older. And if you look closely, it's kind of small print, you can see that it says that the population age 65 and older and Asian Pacific Islander or 65 and older and Black African American reached 100% vaccination in September of 2021. Now, that's clearly not true. Every individual in these groups is not vaccinated. So what's going on? Why does the dashboard say 100%? So the problem is the denominators. MDH gets vaccination counts, which of course, as we all know, are the numerator of vaccination rates. And to turn these counts into rates, MDH needs to know how many people are in each population group. And when the state first constructed this vaccine dashboard back in late 2020, the best and most current available estimates were from the 2019 American Community Survey. And because we were looking at some small cell issues, they had to use the 5-year ACS, which means that the denominators used in that dashboard actually come from 2015 to 2019. And the problem with that is that some older groups in Minnesota, like elderly Black or elderly Asian populations, are growing pretty rapidly. So outdated denominators mean that even if you have accurate vaccination counts, you're attributing those counts to too small of population, which results in vaccination rates that are overestimated. And I want to pause here to note that we're definitely not criticizing MDH here. Minnesota has this problem because it offers more detailed disaggregated data than other states and then the CDC. And we think MDH actually did a really good job trying to construct these rates. We know because they generously shared their R code with us and we went through it in detail and we're impressed at how thorough it was. The population data that they needed just wasn't available at the time. So back to the issue of overestimated vaccination rates. We deal with this issue by adjusting all of MDH's vaccination rates that we pulled from this dashboard by multiplying them by the ratio of the original MDH denominators from the American Community Survey to more recent updated denominators from the National Center for Health Statistics. And unfortunately, this adjustment doesn't completely fix the issue for elderly populations. As we see in this dashboard, the rates that we're adjusting for some of these groups are top coded at 100%. So we don't know in the original MDH calculations if this is supposed to be 100%, 103%, 105% for these groups. So basically, the bottom line is that the initial rates were overestimated for all population groups. And once we apply the adjustment, we get rates that are mostly good for most groups, but are underestimated for elderly Black and Asian populations because of this top coding issue. So because of this, we present results for multiple age groups, including older ages, and then but then we really focus in on the midlife period. Okay, so our headline finding is in Minnesota at midlife, white people are less vaccinated, but still have lower mortality. And I'm going to walk you through what that looks like in detail. So we started by comparing vaccination patterns and COVID mortality patterns across specific periods of the pandemic for two groups, white Minnesotans and Minnesotans of color. And the results on this slide are for the midlife group. So again, that's ages 45 to 64. So the graph on the left shows the cumulative percent of people who are considered fully vaccinated, which we're defining as 2 doses of Pfizer or Moderna or a single dose of Johnson & Johnson. So as you can see in this, in the graph on the left, during the Delta and Omicron periods, the white population shown in purple has substantially lower vaccination rates than the BIPOC population shown in teal. And then the graph on the right shows period-specific mortality for these two groups. And as you can see, BIPOC Minnesotans have higher COVID mortality at every stage of the pandemic relative to white Minnesotans at midlife. And when you combine this information into a single graph, you can really see that vaccination and mortality patterns are reversed from what we would expect. We would expect groups with lower vaccination rates to be less protected and therefore have higher mortality. But what we really see is that in midlife, white people have substantially lower vaccination rates and yet still maintain substantially lower mortality rates. And so this is what it looks like in midlife, and we're focused on that, but I want to briefly show you what it looks like in other age groups. So panel A shows relatively young adults. And in this group, we see that white people are somewhat less vaccinated, and we see that white people have substantially lower COVID mortality, particularly in the recent waves. And panel C shows elderly ages. Again, we don't really know who's less vaccinated here. They look approximately equal, but as we just talked about, some of the groups that make up the BIPOC category are underestimated. And then in terms of mortality in this older age group, white people continue to have lower mortality. But the most striking pattern remains in panel B. At midlife, white people are less vaccinated by a lot, but their mortality is still a lot lower. And these mortality gaps that we see are huge. During both the Delta wave and the Omicron wave, BIPOC mortality at ages 55 to 64 was higher than white mortality a decade older. And so this slide shows COVID mortality for white and BIPOC women specifically, and the dashed line here corresponds to white mortality at ages 65 to 74. And you can travel back along the dotted line to the left and see that it reaches, it crosses the teal line, that the BIPOC group reaches that same level of mortality at age 50 or even younger. And we see approximately the same thing for men, which again is that BIPOC mortality for people in their mid-50s to mid-60s is higher than white mortality for people in their mid-60s to mid-70s. And so the point we're trying to make with the last two slides in these plots is really just that the mortality disparities that we're seeing are really extreme. And I want to note here that we're using this dichotomous white versus BIPOC classification here and in other graphs where we're including older aged individuals because some racial group populations in Minnesota are too small to look at individually in those older ages. And in some ways, the BIPOC grouping makes sense in this context. In Minnesota, the primary mortality divide at all high mortality ages and across all periods is really white Minnesotans versus all others. And one reason that we see this is because the Asian population in Minnesota, which is largely Hmong, is disadvantaged in terms of mortality relative to the Asian populations in many other states where this sort of grouping might make a little bit less sense. But of course, taking such a broad approach has limitations. So we also zoom in on and take a deeper dive into individual racial groups at midlife where the data can support it. So the plot on the left shows vaccination progress at midlife for white, Black, Hispanic, Asian Pacific Islander, and Native groups. And the plot on the right shows mortality rates for those same groups at specific periods of the pandemic. And the big takeaway here, like we see at midlife, Native people have the worst vaccination rates, followed closely by white people. But we see in the mortality figure on the right that white people continue to have the lowest mortality rates of any racial group at every stage of the pandemic. And so this brings us back to the framing issue. If the pandemic of the unvaccinated were the main frame for understanding inequities in COVID mortality, we would expect to see racial groups' mortality follow along with their unvaccination levels. So in these bump charts, which rank groups from worst to best in terms of vaccination on the left and worst to best in terms of mortality on the right, we would expect to see that racial groups' mortality should be ordered with vaccination. And we do see this for the Native population in orange at the top of each plot. Native people have the worst vaccination rates in Minnesota, and they also have the worst mortality rates. But white rates, shown in purple, are way out of order. This group is under-vaccinated, but still relatively protected nonetheless. So is this a pandemic of the unvaccinated? Sure, to some extent it is, but it's also a pandemic of the disadvantaged, and those aren't necessarily the same thing. The fact that population mortality does not reflect population vaccination rates indicates that structural racism, as manifested through systems and policies that affect healthcare access and occupational risk and housing conditions, this structural racism still continues to fundamentally shape the risk of COVID mortality in Minnesota. And so we believe that a pandemic of the disadvantaged framing emphasizes the need for sustained population-based COVID prevention strategies that really center health equity over strategies that emphasize individual behavior. And what comes next? We're trying to take this a step further to understand why people of color have such high COVID mortality despite having relatively high vaccination rates. And this new project is in partnership with MDH and is led by Keely Morris, who, as many of you know, is also a PhD student in Epi here. And so major shout out to Keely, who is a fabulous collaborator and is working super hard on this. Keely would have loved to be here in person, so I can embarrass her, but I believe she's on the Zoom call. So specifically, Keely and the rest of the team are wondering whether racial differences in COVID mortality are driven by inequities among the unvaccinated, inequities among the vaccinated, or both. And if it is driven by inequities among the vaccinated, we wonder if vaccinated really means different things to different populations. For example, if white people, if people of color are less likely to be boosted or more likely to have only received a single Johnson & Johnson shot, we want to know how, whether this is affecting the patterns that we see. So stay tuned for more results from this follow-up study from Keely and Elizabeth and the rest of our team. Elizabeth, back to you.
Yeah, I think maybe what I'll do is, because I want to make sure we spend a lot of time on the discussion, I think maybe what I'll do is skip the slides and just say this last lesson simply. Something that changed the way that I understand pandemic mortality and also racial inequality in the United States was realizing that white mortality during this pandemic is still not as high as Black mortality is year in and year out every year in the United States, even when there's not a pandemic. And one reason I think why that result has been so striking for me and keep coming back to it is, to me, pandemics are special because they're intimately linked with social action, meaning that we do all kinds of things to try to stop them. And it can in some ways feel a little weird to be saying that in 2022 when so much of the sort of like public health struggle is about what we're not willing to do anymore, what this country is not doing anymore to try to mitigate COVID deaths. But even so, if we put ourselves from the perspective of 2019 and think about how willing we as a society were to reorganize like basic institutions, education, government, even like family expectations, just all kinds of expectations about the way our lives would be in order to try to stop these deaths. It poses the question, what if we were as serious about stopping deaths associated with racism as we are about stopping deaths associated with pandemics? What kinds of assumptions about what's normal or how things need to work would we be willing to give up? And to me, that's a kind of fundamental normative reframing that has come out of this pandemic work that has really affected the way I think about racism and is a sort of enduring lesson that I'll take from this. So I will leave it there. And thank you all for your attention. We're so eager for your comments.
you want to manage? I don't know if you can see, are you able to? see the buttons that
I'm watching the chat here,
Okay.
and I'm telling people that are remote to just go ahead and unmute
Okay.
and ask questions if they want to.
They can be heard, okay.
Yep.
I see.
Question. Thank you. It was a great presentation by both of you. Thank you so much. So I'm curious if you adjust for anything in your analyses and if you should be adjusting. Actually. That was kind of one of my thoughts. Like, do you adjust for SES? And should you, if, you know, if we're looking at, you know, would that be kind of an over adjustment? I'm just curious how you dealt with those kinds of questions.
Katie, do you want me to say something about that? Do you want to say something?
You can go ahead.
Okay. Usually we don't adjust for anything with the exception of when we're not looking at specific age groups. We adjust for age, and sometimes we also adjust for sex in comparing population groups. And the reason that we don't adjust for more is, well, there's a practical reason, but there's a conceptual reason that I think is kind of more important. The practical reason is our data are death certificates, and there's a vast variation in the quality of variables on death certificates. Things like age are good. Things like racial groups are mostly pretty okay. The biggest exception is for Native populations, and that is something to pay attention to. Things that measure SES, so things like education level, are more dubious. And there's a lot of work by demographers on the way that our understanding of mortality by education groups kind of gets distorted by the fact that our numerators come from death certificates where someone else is reporting the decedent's education, but our denominators come from usually survey data where people are reporting their own education, and they don't always actually line up that well. So that's a practical reason. But the conceptual reason, I think, is that I see these results as fundamentally descriptive, and the enterprise that we're engaged in, I think, is not trying to sort of isolate what is race per se, separate from the pathways through which racism works. But the enterprise that we're trying to do, I think, is more to document the scale of disparities, and then sort of think theoretically about where might they be coming from. And so I don't think that the analyses that we're doing are really good for trying to pin down what is the source of these disparities. But I think that the work of actually understanding what the disparities are is sort of like foundational for anything else that we might do. And in some cases, I think it has actually been because of things like the denominator trickiness, like it's actually been surprisingly hard to just figure out what exactly are the disparities at different points in the pandemic. And so that's really what we've been engaged in.
Again, thanks for a great presentation. I'm Simon Rosser. Most of my work has been in the HIV pandemic. And the thing that strikes me about the COVID pandemic and about this presentation, it's really hard to intervene on things like urban, metro, and rural living. But I'm wondering about equivalent work done in around politics, because what's striking with the COVID pandemic that didn't happen in the HIV pandemic is that you had two large different media sources giving very different recommendations broadly as a proxy measure, Democrats versus Republicans in the United States. And I don't know if that work's been done or whether you're intending to do any work or equivalent analysis by politics.
We've done a little bit, and other groups have done more in the this vaccine project that we talked about, where we age standardize and look at vaccination patterns. I don't show the plots here, I cut them for time, but there are also, we also looked at the share of Trump vote in each state, and sort of how that affected the patterns that we were seeing. And I'll let Elizabeth jump in to say what we found, because she was the one who ran that analysis.
Oh, sure. So we found that there's just a really clear gradient for pretty much every racial group, the least for Hispanics, but basically across the board, there's a clear gradient where the heavier that a state's Trump vote was, the less vaccinated its populace is relative to what you'd expect by its age distribution. And other people have found similar things at the county level and now at the individual level too. And I guess one thing I just want to say about these kinds of results, ours and others, is I think it is a little tricky to interpret them. Because the interpretation that feels most natural is to say like, oh, Trump voters aren't getting vaccinated. But places where there's a lot of Trump vote are also places where the public health apparatus is probably quite different. They're probably places that have had a long-term lack of investment in public health. And as Rachel mentioned, like I've been part of this community vaccination project in Seward with Inari Mohammed from your program. And doing that work, I think, has really driven home to me how difficult it can be for people to get vaccinated, even when they're quite open to it. And so, I think we have this similar kind of gradient for racial groups between the politics of their area and their vaccination rate. But what is going into that gradient is not necessarily the same for everybody. And it may be that for some racial groups, it's more heavily about a kind of like ideological, self-conscious rejection of vaccination. And for others, it might be much more about like getting vaccinated depends on the quality of the vaccine outreach that exists. And there might be people for whom both are true as well.
If I can follow up, I agree with your comments on Inari since she was on our study before she came to you. She's amazing. But has the equivalent work been done around mortality? Is it the Republicans more who are dying than the Democrats?
Yes, it is. So we haven't done that work, but other people have started to do it. And it absolutely is true. And so, there's probably interesting work to be done on the election that we just had, right? On some of the like sort of close calls. Did it matter? I study mortality selection in my other pre-pandemic life. So like the way that populations have been shaped by mortality, and some of the important work in that area is about how voting patterns in certain key races in US history might have been different if it were not the case that Black Americans die so much younger than white Americans. But now I think we could ask the question about, how much is it mattering that Republicans have died disproportionately most recently?
Yeah, chat. Is there something in the chat?
Oh, that's just a different screen where I'm not
Sorry.
checking it.
I have a comment that's not actually related to the topic, but I just wanted to say that it's so great to see this beautiful collaboration between Elizabeth at MPC and you, Katie, and just it's come up again and again with different students. So
Yeah, Elizabeth's very popular among the MP students. Yeah, I will say that for both of us, the Minnesota Population Center has been a real rich source of collaborations, and I'm involved in the interdisciplinary population health science training program there, which specifically asks students to seek out a social science mentor. So the health students from our side have a social science mentor. So my official sociology mentor is Rob Warren, who I've worked with. And then over time, I've sort of developed this bonus sociology mentor in Elizabeth, which has really been rewarding.
yeah, and I'm hoping Heather and Andy are going to come, and that'll be better. And with Teresa over there, it's just so
Definitely.
it's great.
Lots of great people.
Yeah. And it would be great to deepen those connections too. So, if all of you see other ways in your, work life that we can have more connection between what you're doing and the Pop Center, for example, I think that would be fantastic.
Back to you also, coming from both sides. There's a
question.
Sonia?
So what do you see as next steps to better understand the mechanisms
Yeah.
behind these associations?
Sure. I think the project we mentioned that Keely's leading is one. And so, you know, there are pieces of this that we assume are various aspects of structural racism. And one piece of that is, you know, Elizabeth and I have both been wondering for a long time, and Keely too, what is the effect of Johnson & Johnson being sort of not pushed, but disproportionately distributed in more disadvantaged communities. So that's been a question that's really been on a lot of people's minds, but it's a really hard question to answer. The project that during my section of the talk it's an ecological project, right? It's a population level analysis. We didn't have the individual level data to do it, but this, and we were working sort of tangentially to MDH on it. They were consulting a little bit on the project, but this next step is sort of a more in-depth collaboration where MDH has that data. They have the individual data to be able to answer those questions about, you know, to look specifically at different types of vaccinations people have received and mortality. And so Keely, who is a senior epidemiologist at MDH, is leading that project. And through this great collaboration that we've developed, they're able to do it on their end where we're sort of consulting on the analysis, and that prevents us from having to go through really elaborate like data access processes. And it also it leaves a little pressure from the MDH side as well, because they don't have a ton of time to write up papers and sort of really think about these sort of like more complicated types of analysis. They're sort of putting out fires every single day. So just like Diana was mentioning that like the collaboration between sociology and epidemiology is great. We have recently, like this collaboration between more applied public health at the state level and the university has been really fruitful and I think is moving in promising directions.
Thank you. I so enjoyed this presentation.
Thank you.
Thanks to you both.
Any other questions in the Zoom room?
Okay, should I do a closing and then you can do a final closing? I just want to say thank you so much to both Elizabeth and Katie for presenting this work. This was, I was on the edge of my seat the whole time. It was a fantastic presentation, and Elizabeth, I hope we can have you over to the WBOB sometime soon. So thank you both, and have a nice rest of your Friday.
Thank you all.